Alright, so anticoagulants, antiplatelets, and thrombolytics. Week 10. So for hemostasis, we have two stages. We have first stage 1, which includes vasospasm, which helps to reduce how much blood flow we have going through a blood vessel. The platelet plug forms to help plug up whatever the trauma was to the vessel, and that all allows for platelet aggregation to occur. Stage 2 is going to be coagulation, which can occur via either the intrinsic or the extrinsic pathway. And then something to be aware of is that we have both primary hemostasis and secondary hemostasis. Primary hemostasis, the purpose of this is to promote vasoconstriction and platelet activation for the purpose of forming a platelet plug. After we form this platelet plug, we then have secondary hemostasis, which involves the coagulation cascade, converting fibrinogen to fibrin to form, the goal being to form a blood clot. And from there we can also have control of that blood clot via fibrinolysis and clot degradation antithrombotic mechanisms that are naturally occurring in our body. So remember also that thrombi can be either arterial or venous. And we have three main groups of drugs for coagulation. We have actual anticoagulants, antiplatelets, and thrombolytics. For specifically our anticoagulant therapies, we have antithrombin activators such as heparins. We have our vitamin K antagonist, which is warfarin. We have direct thrombin inhibitors and direct factor Xa inhibitors. So overall, the purpose of anticoagulants is that we're reducing fibrin formation. And looking back on here, fibrin is right there. We're trying to prevent fibrin from being made. That's what heparin is going to be, or anticoagulants in general, are trying to promote. And by doing that, we inhibit the synthesis or activity of clotting factors. So heparin unfractionated, which in the hospital setting is just simply going to be heparin, is going to be one of our main anticoagulants. And typically this is going to be only given IV. Sometimes we may give it subcutaneous, though from what I've seen, subcutaneous is traditionally given with Lovenox rather than heparin. It comes from bovine and porcine sources, being cows and pigs, and it is very rapid acting. So again, the anticoagulants are affecting the formation of fibrin. So we're going to be using this for anything we need to worry about utilizing rapid anticoagulation for. So if we have a PE or a DVT, ischemic stroke, we're going to be using this in response to try to limit how much damage that clot can cause. And on top of that, we also want to try to break down some of those clots. Depending on how severe these clots are, we may use something more powerful, but heparin is kind of a classic medication for this. We'll also give it prophylactically, post-operatively in a low-dose form, because a lot of post-operative patients are going to be supine or still in bed for a long time, and that's a risk for developing a clot. And this way we can just ensure that they don't have clot development. We also use it adjunctively with thrombolytic therapy in MIs. So we will use alteplase, TPA, which is the most powerful clot buster that we have for someone who's experienced an MI, if they qualify to use it. And then we'll use heparin unfractionated in addition to that to just have sort of this double power whammy to take care of clots. Both forms of heparin that we're going to be talking about are okay to use in pregnancy, whereas warfarin is not okay to use in pregnancy. So with all of these blood thinners, anticoagulants, antithrombotics, we're going to be having hemorrhage as a very significant potential side effect because we're inhibiting how well the clotting cascade can work. So we have the potential of hemorrhage. We also, as with any medication, have the potential for hypersensitivity reactions. So, but with specifically heparin, some more people have had problems with hypersensitivity. It is completely contraindicated, though, if we have thrombocytopenia, low platelet counts, or uncontrolled bleeding. So we have a trauma patient comes in who also had a myocardial infarction. We're not going to be giving thrombolytics or heparin to treat that MI because they're bleeding, they have a trauma. We also want to be careful when giving it, or it may be completely contraindicated for patients who had surgery of the eye, brain, or spinal cord because these are all areas that are very susceptible to increasing pressures from a lack of coagulation in that area. So if a person were to start bleeding out in the spinal cord or in the brain from the surgery because they're giving heparin, then that's going to increase the pressure, which they're very susceptible to. We're also going to want to make sure that we're closely monitoring whenever we're giving heparin unfractionated, monitoring the activated partial thromboplastin time, APTT. Sometimes it's also just called PTT. So this is going to be indicating how quickly are people clotting. APTT is specifically used for heparin, whereas PT and INR are specifically used for warfarin. Our goal here is to have a prolonged APTT time of 1.5 to 2.5 times normal amounts, normal time, when they're on heparin. If they are above this, that indicates that they have too much heparin, and we need to be on the lookout for any potential bleeding, and we may need to consider holding back medication because they're outside the scope of, or the reference range that we want them to be in. If they're under 1.5, then there's a potential that they may not have enough therapeutic effects from heparin for what we're looking for. And then if they do have a APTT time that's above 2.5 and they're showing signs of potential bleeding or showing signs of any other kind of hypersensitivity reaction, we will give then protamine sulfate to counteract heparin. Low molecular weight heparin, also known as enoxaparin or Lovenox, is another medication that you're going to see a lot of times in the hospital, and this is the one that I've seen more often used directly on post-operative patients because it's generally easier and has fewer side effects, but it is more expensive. So again, we're going to be using this post-surgically for prevention, of course, or differently than heparin unfractionated. The prevention of DVT can be treated with heparin low molecular weight, but not heparin unfractionated, except for post-operative. But some people might be able to use this outside of the hospital. Prevention of ischemic complications with unstable angina and STEMI or STEMI. So people may be actually able to use this outside in their homes as opposed to having to be in the hospital while receiving this treatment. And again, like heparin unfractionated, this is okay to give in pregnancy. We do still have the potential adverse effect of hemorrhage with Lovenox, but it is less than it is for unfractionated heparin, and we still have the potential for hypersensitivity reactions. Just like heparin unfractionated, if they have low platelet counts, thrombocytopenia, or uncontrolled bleeding, or surgery of the eye, brain, or spinal cord, they're either going to be contraindicated or they're going to have very strong cautions used to ensure that no damage occurs from giving this medication. Unlike heparin unfractionated, we do not require monitoring of Lovenox, which means we are able to give this at home subcutaneously. Again, the antidote, if someone were to come in from, say, a trauma and they were already taking heparin, and now because they're on this Lovenox heparin, they're bleeding out more than they would be normally. We're inhibiting the coagulation cascade associated with this trauma, then we can give protamine sulfate to reverse the Lovenox and allow them to clot and not bleed out. Warfarin is a very common medication to give to patients. This is our vitamin K-dependent clotting factor antagonist. It specifically is going to be affecting or inhibiting factor 10 and prothrombin. This is also something that we can find in spoiled clover silage, in rat poison to help promote bleeding and kill a rat, and we can be given this orally. So this is kind of a nice little diagram that shows sort of the coagulation cascade. So we have the intrinsic activation, and then we have the extrinsic activation. The intrinsic activation has to do with responding to damage that occurs from inside, or stimuli that occurs from inside the blood vessels. There's no actual damage to the vessel as a whole. Extrinsic activation occurs from actual vessel injury. So this is where we're going to come in with trauma. Intrinsic activation could be coagulation that occurs from, say, endothelial damage, whereas extrinsic, we're going to have, I think it's peri or epithelial damage, the damage to the outside shell of the vessel that actually penetrates through to the inside, full thickness damage to a vessel. Warfarin is going to be specifically along this cascade. Both the extrinsic and the intrinsic are going to be trying to activate factor 10A, and factor 10A will try to convert prothrombin to thrombin, which will then try to convert fibrinogen to fibrin, which continues on to form the actual blood clot. Warfarin is going to block factor 10A, or factor 10 and prothrombin specifically, which are both part of the vitamin K clotting factors. So for where were we? There we go. So warfarin is not useful in emergencies. It is much more slow acting. You're not going to be noticing benefits until much later on, as opposed to heparin, which has a very rapid acting action. We're going to be using it instead for long-term prophylaxis or prevention of thrombi. So we're going to use it to prevent PEs or DVTs, and we're going to be using it prophylactically in patients who just had a prosthetic heart valve replacement, or they got a new prosthetic valve. These patients are, along with atrial fibrillation patients, at high risk of developing a clot because they have this new valve in their heart, which can promote turbulence until the body kind of adapts to it. With atrial fibrillation, we also have the potential of developing a clot because these quivering, these fibrillating atrias promote turbulence in the blood in the atria, which anytime we have turbulence, anytime we have potential stasis of blood, we have the potential for developing a clot. Again, along with all the other ones, we have the potential adverse effect of hemorrhage. Unlike heparin, warfarin is contraindicated in both people who are women specifically. You're not going to find men who are pregnant. Well, you might actually nowadays. Yeah, you might. People who are pregnant or people who are lactating. Well, specifically breastfeeding, not just lactating. So if we have someone who is pregnant and they take warfarin, there's a potential that it can cause fetal hemorrhage inside, in utero. It can also act teratogenically in the development of the baby. And if they're breastfeeding, then there's a potential that that can actually go out through breast milk into the baby themselves, causing severe reactions in an infant. With warfarin, unlike with heparin, we're going to be monitoring PT, prothrombin time, and INR, international normalized ratio. But with heparin, we're looking at APTT or PTT. The antidote with warfarin is phytonadione, or vitamin K1. With warfarin and with a lot of other, if not all other anticoagulants, if we give another form of anticoagulant, we're going to simply increase the anticoagulant effects and promote more hemorrhage. So we're going to want to be careful, of course, giving it with heparin or aspirin. And weirdly enough, Tylenol, acetaminophen, we're not sure why that is exactly, but giving both acetaminophen and warfarin has the potential of increasing bleeding. So when we're going through, we want to make sure that we're asking our patients what medications are you taking, what over-the-counter medications are you taking, what supplements are you taking, what herbs are you taking, because they can all potentially interact with these medications. We're also going to want to be careful with having patients take oral contraceptives while they're on warfarin, because the oral contraceptives actually have the potential of decreasing the anticoagulant effects. So instead, maybe they can use a NuvaRing, or they can use an IUD, or the depot shot. So that's warfarin. Now we're moving on to our direct thrombin inhibitors, which is going to be dabigatran, or Pradaxa. This directly inhibits thrombin. So as we see down here, we're actually directly inhibiting thrombin, which is used to convert fibrinogen to fibrin. So a lot of other ones were affecting fibrin specifically. We're now going one step above and inhibiting thrombin instead. So this is a newer medication, and what's really interesting about it is it's actually a prodrug. So a prodrug is actually a medication that is entered into our body in an inactive form. It doesn't have any actual actions that it can create on the body until it's acted upon by another chemical, whether that's an enzyme or some other kind of chemical that some localized part of the body produces. That's in general great, because that can cause fewer side effects that way, and we get more concentration of the drug itself directly to where we need it. This medication is one that we're going to be taking at home and has a rapid onset. So this is a medication that is a little more stable for patients to take at home rather than heparin. So we're going to be using this for AFib, again, because that fibrillating atria causes stasis of the blood through turbulent blood flow. We're also going to use it prophylactically after a hip or knee replacement, because those kind of patients are at high risk of developing a clot within the venous system, leading to a DVT or a PE. We have still the same kind of adverse effects as other ones, which primarily is bleeding. But what's interesting is with dabigatran, and actually this also goes for rivaroxaban, we have the potential of developing dyspepsia, which is a fancy way of saying heartburn. I don't remember why that is, but it's something to remember for the test. For dabigatran, we do not require any monitoring of anticoagulation, so we let them go home. If they come back with a potential for bleeding risks, with a trauma or something, then we can give them the antidote, which is pronounced idarucizumab. Idarucizumab. They actually have a little YouTube video that shows how to look it up, or how to say it. It worked pretty well. Alright, so that was our direct thrombin inhibitor. Now we have our direct factor 10A inhibitor, which is going to be rivaroxaban, or Xarelto. This binds directly to factor 10A to inhibit the production of thrombin in the first place. So back up here, no, that one didn't work so well. So this is also a newer medication and has a rapid onset after being taken orally. So rivaroxaban affects factor 10A. By blocking factor 10A, we prevent prothrombin from being converted into thrombin. So we had fibrin earlier on being able to be blocked itself. Then we went up one step to block thrombin. Now we're going up one step further to block factor 10A directly. So again, this is very, very similar to dabigatran. We're going to be using it for AFib, knee-hip replacements for DVT and PE prophylaxis. There's a decreased risk of adverse interactions, which is really good. So we're going to have decreased bleeding risks, potentially decreased dyspepsia risk. And again, there's no monitoring required for rivaroxaban, so patients are able to easily take this at home without much of a concern. We do have the potential of P450 inducers or inhibitors interacting with this medication, as well as P-glycoprotein inducers or inhibitors, um, anti-seizure medications, and St. John's wort, which is a very common medication for menopause and PMS, as well as I think some other uses, which is an over-the-counter supplement and not well regulated. So a lot of people may be thinking that they can take this without any problem, not realizing that it can have some very significant interactions with medications. So again, we always got to make sure that we're asking our patients, what supplements are you taking? So rivaroxaban is also, we want to give it cautiously in patients who are pregnant. We'd prefer to give it to something or give them something else instead that is safer to give because there is a potential increased risk of hemorrhage. And then also, if they have any form of hepatic or renal impairment, this kind of goes for most medications. Hepatic is going to be, the liver is going to be metabolizing medication, and the kidneys are going to be the ones excreting the medication out into the system. So if either one of these are impaired, we're going to have an increase in levels in the blood, leading to a potential for increased effects from the medication. So we have also some natural anticoagulants. I don't know exactly how really effective these are, but we have feverfew, ginkgo, garlic, ginger. So if we have a patient, for example, who has, and this is where we're going into, where's that education? Lifestyle factors, drug and food herb interactions. So when we get a patient who we're producing or providing education on for a new anticoagulant therapy, we're always going to have to check, what drugs are they taking, what foods are they taking, and what herbs are they taking as well, because we do have a number of foods and herbs that could potentially impact synergistically the anticoagulant therapies. We always want to make sure that we are monitoring for signs of bleeding, so looking for bruising, turning them around on all sides just to check, checking blood pressure, how does that look, checking for skin turgor, cap refill. We always want to teach proper mode of administration. So, for example, that comes in specifically important with heparin Lovenox because we're giving that subcutaneously. So we want to make sure that those patients know how to give a subcutaneous injection, how to rotate sites appropriately, and how to monitor for risks associated with giving a subcutaneous injection. We want to make sure that they're aware of how often they need to have lab monitoring and the importance of lab monitoring, given that if you don't monitor it, they could end up getting to dangerous toxic levels and potentially die. We also want to make sure that they are aware of the need to stop prior to surgery or spinal procedures. All right, so now we have our actual antiplatelet drugs. So platelet aggregation is required to promote clotting. They make up the core of arterial thrombi and are the primary indication, or what am I saying here? So the use of antiplatelet drugs is primarily used for the purpose of preventing a thrombus formation because they do make up the core of arterial thrombi. So the main one that we are really concerned about is aspirin. This is the one that we're going to be using primarily with most patients. We're going to be seeing this commonly with a lot of elderly patients. It does a really good job of suppressing platelet aggregation, and it does so by irreversibly inhibiting cyclooxygenase. So this is irreversible antagonism. So that doesn't mean that it's permanent, because irreversible means that it's only going to last as long as that receptor lasts. Once that receptor and the irreversibly bound molecule attached to it dies, then the new receptor is not going to have any problems producing its or being open for activation. So for our therapeutic uses, anytime we do percutaneous coronary interventions, we're going to be using antiplatelet medications and probably continuous throughout the rest of their life. People who have ischemic strokes or TIAs, which are like mini strokes, chronic stable and unstable angina, These folks are going to be on aspirin for the rest of their lives, and then we're also going to have it as prevention for acute and previous MIs. A lot of times we're going to see patients who are just literally on this from the moment they have some sort of a cardiac issue throughout the rest of their lives, because aspirin's amazing. It's a really great medication. One thing to be concerned about is a lot of patients will find out somehow that the emergent use of aspirin comes with a dose of 324 milligrams, but the typical daily dose for aspirin for patients not in an emergent situation is 81 milligrams. And so what you might end up having are these patients who think more is better, and they'll have better protection by taking 324 milligrams, and they'll do this without even consulting a medical professional. So we always want to also check to find out how much are you actually taking. Are you taking the right dose that you're supposed to take? Because this is just simply an over-the-counter medication. And if they are taking 324 without consulting anyone, educate them on the need to stick with the medication or the dose that they were given, and then consult with their prescribing physician about whether they should bump up to 324 or if they should stay at 81. Again, we have the adverse effects of bleeding, hemorrhagic stroke, and GI effects. So people who have peptic ulcers, there's a potential we're going to be making this a lot worse, or we may even actually cause peptic ulcers with aspirin. So Plavix, or clopidogrel, is another common medication that we can see patients on. It's not as common as aspirin because aspirin's cheaper and it's easier to access. This is a adenosine diphosphate (ADP) receptor antagonist. It will irreversibly prevent platelet aggregation, similarly to aspirin. We're going to be using it for virtually the same kinds of problems: coronary artery stenting, TIA, stroke, stable, unstable angina, and for MI. The adverse effects are very similar to aspirin, but the difference between clopidogrel and aspirin is that we have a slight decreased risk of GI bleeding. So we don't have, it's not as easy to get access to Plavix. You have to go through a prescription. You have to have refills. You can't just go to your Walmart and pick up something off the aisle like aspirin. You have to actually go through the prescription situation. But the benefit is we have a slight decrease in GI bleeding, which a lot of older adults have a propensity towards having GI bleeding. So our next antiplatelet drug are the glycoprotein 2B3A receptor antagonists. So these provide reversible blockade of platelets. Platelet glycoprotein receptors. So, I mean, I need to look more into that. I'm not sure exactly how that works. But they inhibit the final step in aggregation and are given IV. So the thing about them is that they are the most effective antiplatelet medication that we can give. It's the super aspirin. We're only able to give it IV. That's part of the reason why it's given IV because of the fact that it is so powerful. We are only going to give it for short-term prevention of ischemia associated with ACS or arterial procedures. It does have the adverse effect of hemorrhage, like most of them. This one might be a little more powerful of an adverse effect. So when it comes to the antiplatelet medications, aspirin works high up in the chain here, about the same level as clopidogrel or Plavix, preventing platelet recruitment and activation. For these medications, the glycoprotein 2B3A antagonists, I'm not going to try to pronounce those, these are going to specifically prevent platelet aggregation. The big thing to remember about them is that they are reversible in their blockade of platelet receptors. They are given IV, and they are the super aspirin used for short-term prevention with emergent situations or arterial procedures. All right, now we have our thrombolytic drugs, which I think is really just one drug. This is going to be alteplase, or TPA. Most of the time you're going to hear TPA in the hospital setting. These are going to be removing thrombi that have already been formed. So a lot of the medications, if not all of them that we've talked about, are more about prevention or preventing progression of a current clot. Alteplase, TPA, is basically our main clot buster. So this is going to promote conversion of plasminogen to plasmin, which is required for degrading fibrin in thrombi. So we already have a bit of plasmin in our body, but this is going to promote a tremendous amount of plasminogen to convert to plasmin to destroy these clots. It is administered IV because that's the way we have the fastest activation. And for uses, we're going to be talking about MI, ischemic stroke, massive PE, the things that have the highest risk of very severe side effects if we don't have rapid administration with this super powerful drug. We have to make sure that we are giving it early. Most of the time we're talking about a 30-minute window. And for adverse effects, clearly hemorrhage. And if we give too much, we're looking at aminocaproic acid as our antidote. So when it comes to nursing implications, especially with TPA, we want to minimize physical manipulation of the patient. We want to make sure that we don't have any potential cause for bleeding in the body, because once we give TPA, it's very difficult, even with the aminocaproic acid, to reverse the TPA. There's a very good chance that they could just simply bleed out. We want to also avoid giving anything that is used as a puncture into the skin or any invasive procedures for the same reason. We want to minimize any concurrent use of anticoagulants. So we would probably want to cut out heparin, not give our doses of warfarin or dabigatran, because we don't want to have this synergistic effect. Heparin may be used afterwards, especially unfractionated heparin, to sort of stabilize the effects of TPA, but we probably would not want to give it along with TPA. We also want to make sure that we're not giving any antiplatelet medications right away or along with it. We will probably have, for MI patients, maybe TPA or stroke patients, may give them aspirin, because that's kind of the common protocol. We give them that first upon seeing any MI issues, but we're not giving continuous doses of aspirin along the time period where we lead up to giving TPA. So the effects of aspirin may not be as pronounced along with giving TPA. This is a nice little chart that shows sort of the relationship of all of these together. I don't think you need to remember all of these terms. Remember dabigatran, remember enoxaparin, heparin, warfarin, rivaroxaban. I'll put little dots next to these. So dabigatran, enoxaparin, heparin, warfarin, rivaroxaban, clopidogrel. Y'all already know aspirin. I'm not sure why they don't have alteplase on there. Those are the ones you need to remember. Alright, so for antidysrhythmics. So we have here our EKG rhythm. This is going to be normal sinus rhythm. So the parts we have are the P wave, the QRS complex, and the T wave. We also have like the PR interval, we have the ST segment, we have the QT segment. The P wave itself represents depolarization of the atria. The QRS complex represents depolarization of the ventricles. And then the T wave represents repolarization of the ventricles. The atria will also have repolarization as well, but typically we're not going to see it because when you compare the size of the ventricles repolarizing to the size of the ventricles depolarizing, you can tell that it's a smaller wave for the repolarizing component, which means that this P wave, the atrial repolarization, is going to just kind of be hidden here somewhere in the QRS complex. But because this is such a massive depolarization, it's just going to kind of obscure the atrial repolarization. For dysrhythmias, we can have, they are just simply an abnormality in the rhythm, the electrical conduction system of the heart. So we can have a bradydysrhythmia, we can have a tachydysrhythmia, along with other ones. Brady rhythms in and of themselves are not considered, nor are tachy ones considered pathologic. They are a dysrhythmia when we're talking about an impact to the hemodynamics or the hemostasis of a patient. So they become a bradydysrhythmia when the rhythm itself is too low, too slow to produce enough cardiac output. A tachydysrhythmia is a tachyrhythm that exists for no good cause. So a person who is working out, who may be a little bit stressed but not extremely stressed, more eustress versus distress, then they may experience a tachyrhythm to maintain cardiac output and the increased oxygen demand that the body has. But if a person while at rest has this tachyrhythm of like 120 or 130, but they're totally at rest, that becomes a tachydysrhythmia. Technically, anything below 60 is a bradydysrhythmia until proven otherwise, and anything above 100 is a tachydysrhythmia unless proven otherwise. And what's important here also, for everyone to make sure they remember, is that virtually all drugs that treat dysrhythmias can also cause dysrhythmias. So that medication that we give to treat bradydysrhythmias could lead then, because we're trying to amp up the heart rate, could lead to a tachydysrhythmia and vice versa. So for bradydysrhythmias, there are a fewer number of them compared to tachydysrhythmias. And this is a dysrhythmia where the heart rate is slowed to the point where it is somehow a problem. Not talking about someone who is simply in very good shape and their resting heart rate's in the 50s or 40s. We're talking about someone who is actually having a problem because their heart rate is so low. So most of the time, these are treated with pacing. We can give atropine short term to try to amp up their heart rate. In times of emergencies, we may give dopamine or epinephrine, norepinephrine. There are a number of medications we can give to try to amp up the heart rate and contractility for someone who is Brady. Most of the time, those are more emergent medications. Pacing is a more long-term option, and it is also able to be used in the emergent setting as well. But for long-term treatment, we're going to have an actual pacing implantation into the chest that sends a signal when needed to the atrias to fire to make sure that they keep at the right rate. And this actually is a painless experience. Patients don't even realize that the pacemaker is going. They recognize when it's not going because they start to feel like crap. For times when we might need to amp up the heart rate with a drug, we may use atropine. So atropine is a muscarinic antagonist, and muscarinic receptors are the receptors associated with the parasympathetic nervous system. So these are the receptors that are used to put us into the rest and digest mode. So if these fire, they're going to make us more Brady. By providing competitive blockade at muscarinic receptors, we are able then to inhibit any form of parasympathetic activation. So we won't necessarily be promoting sympathetic activation, but we'll at least be blocking any parasympathetic activation. And really what we're doing here is we're preventing the receptor from being activated by acetylcholine. For antidysrhythmics that are associated with tachyrhythms of some form, we have several classes here. Everyone's familiar with beta blockers and calcium channel blockers. A couple other ones that we also have are sodium channel blockers and potassium channel blockers. And to put sort of a name to each of these, the sodium channel blocker would be lidocaine, and our potassium channel blocker would be amiodarone. So these are medications that we're going to be giving especially for ventricular dysrhythmias. I think amiodarone has also kind of progressed in protocols to include some atrial dysrhythmias as well. Both of them reduce, by blocking certain channels, they reduce the rate that the heart can beat at. So if we had a patient in, one of the more common ones that we might use them for is ventricular tachycardia. So that's a rhythm where the electrical impulse actually begins in the ventricle and can then, it doesn't actually even associate the atria at that point. It's a very dysfunctional and can be a very dangerous rhythm. We never want to see a patient who is constantly in VTAC because it's not sustainable with life. They may have a run of VTAC, meaning that they have a brief couple seconds where they have VTAC, and then they convert back on their own into a normal rhythm that's more stable. So we might give for VTAC one of these medications to slow the rhythm and allow for the natural, normal sinus rhythm to take place again. For beta blockers, calcium channel blockers, most of the time these are going to be used specifically for just a fast rhythm, maybe for an atrial-based rhythm as well, like atrial flutter, maybe atrial fibrillation. It depends on what the recent science and protocols indicate. For a supraventricular dysrhythmia, this is going to be one in which the original impulse for this rhythm comes from somewhere within the atria, meaning that we have supra, meaning above the ventricles, and above the ventricles would be the atria. So these can actually be pretty varied in how severe they are. If they are simply 130s, 40s, that may not be terrible. They're still going to be capable of producing the right output. But if you bounce it up to 180, 220, we're looking at some very significant rhythms where you may not have much in the way of a cardiac output. For a ventricular rhythm like VTAC, ventricular tachycardia, or VFib, ventricular fibrillation, these are a significant pump disruption that may require cardioversion. And these also really only respond well to class 1 or class 3 drugs. So we're talking our sodium channel blockers like lidocaine or our potassium channel blockers like amiodarone. And just to kind of go over this a little bit, cardioversion is specifically, it's like defibrillation. Defibrillation is what you're going to see with an AED or when a person has cardiac arrest. They're on the floor, people are doing CPR on them, they attach the pads or the paddles, and they shock them. That's defibrillation. And cardioversion is like that. Defibrillation is more powerful. It has a higher level of electricity that is used to shock them. Cardioversion has a lower level. And cardioversion is only used on patients that have a pulsing rhythm. So if you feel a pulse, regardless of whatever kind of tachy rhythm you see, then you're going to use cardioversion before switching to defibrillation. Defibrillation is really only going to be used for non-pulsing beats. Of course, the protocols may have changed since I last learned about this, but regardless, so the next big thing also is that cardioversion has a shock that lands on a beat. It has to be synchronized with whatever rhythm is showing so that it shocks at just the right moment, as opposed to defibrillation where it's a random shock. Whenever you hit the button, that's when it shocks. And it's not important when you hit the button for defibrillation, but it is important that cardioversion lines up on its own. so that it shocks at just the right time to convert the rhythm. When we give any kind of antidysrhythmic or using a cardioversion, we want to make sure we're balancing the risks and benefits. We got to make sure there is an absolute clear benefit that outweighs the risks, because we're talking about some very potent and potentially harmful medications that can cause very significant damage. We can even send someone into cardiac arrest with these medications if given improperly or at the wrong time. Use of dysrhythmia, or we want to use if the dysrhythmia interferes with ventricular pumping. So if we have a clear indication that they don't have enough cardiac output and they are declining, they're decompensating, we want to give these medications. But we got to make sure that we're aware that we may actually increase mortality with use, because there's always a chance that that dysrhythmia, or the antidysrhythmic that we give, lidocaine, metoprolol, propranolol, amiodarone, verapamil, we may actually convert them into a different rhythm that is equally as dangerous by using those medications. And then what are we doing? Are we bouncing back and forth from one medication that brings them up and then one medication that brings them down? And that's just going to put all sorts of wear and tear on the system and the heart in particular. And just remember that anytime we use an antidysrhythmic medication, that also makes it a pro-dysrhythmic medication. We can exacerbate any existing dysrhythmias or even create new ones. Which means we want to make sure that we are starting with low doses here. And then after they've converted, we're going to want to monitor with a Holter monitor for a period of maybe 2 weeks, perhaps longer than that, depending on how significant the dysrhythmia was and how significant their hemodynamics were impacted. We're going to want to monitor their plasma drug levels, because we want to make sure those drugs don't go into the toxic level and potentially cause significant long-term damage. If they are going to be on something long-term, some people do take lidocaine or amiodarone or a beta blocker. Beta blockers are very common. Anything long-term to try to prevent these dysrhythmias, we want to make sure that we are reviewing what other medications they're taking so that we can ensure there are no dangerous drug interactions occurring. We also want to teach the patients how to recognize the signs and symptoms of a dysrhythmia or of heart failure, because time is muscle. Anytime, and that normally is used for treating an MI, but if you have a dysrhythmia, you got to treat it quickly, because the longer you wait, the more likely it is that you're going to have a progression of that dysrhythmia to an even more dangerous dysrhythmia, depending on what kind it starts out with. For non-drug style treatments, we can also have implantable cardioverter defibrillators, which look and act very similarly to pacers. They are planted under the skin, similarly to a pacer. They have a wire that goes up into the heart, or down into the heart. And the difference is that they have, instead of an initial or a pacing that occurs every second, every half a second, whatever it would be for pacing, the cardioverter defibrillators will analyze the rhythm at all times and determine whether or not they need to be converted. So if the patient has issues going into and having runs of V-tach, and their blood pressure tanks when they experience this V-tach, then this little implantable cardioverter will shock the heart, perform a synchronized cardioversion, shock the heart back to a normal rhythm, and they'll be good to go. They'll then have to contact the doctor and determine, do they have anything else they need to be worried about, or are they good to go. We can also have ablation of a portion of the heart that is causing a dysrhythmia that would often be along with or associated with atrial fibrillation, Wolff-Parkinson-White syndrome, maybe atrial flutter, anything where this sort of extra loop pathway in the heart exists to make the heart just go that much faster, especially in the atrias. And then, of course, as we talked about earlier, we also always have the potential of cardioversion. And sometimes cardioversion is the best choice, because using electricity you're able to stop it immediately. You don't have this situation where you're pumping in medications into the body, and all of a sudden, oh, I wish I hadn't done that. Well, I can't just yank the medication out. I have to now support them and find a way to ensure that medication makes as little an impact on them as possible until the body metabolizes it. Whereas cardioversion, you shock them. If you don't want to continue shocking them, you pull it off and you're done. And there's no more shock going on. One of the benefits of cardioversion. But we want to reserve cardioversion for times when we absolutely need it.